ESG showed a TR4 nodule. It is an FPTC. Generally, this is how the scan looks. Cold nodule, we classically call it. Trust me, there is no indication of doing thyroid scan in nodular evaluation these days. A good ultrasound, a good report is good enough with an FNAC in place. People send it to us, we do the scans. That's how the clinical practice goes on. So there are two scenarios. Either it is a clinically palpable nodules, incidentalomas. So solitary thyroid nodule will be cold and warm. I will just show you how the warm nodule looks like, because that's quite interesting. I remember a very senior nuclear medicine physician from this city, from All India Institute, Shoikat Chaudhary, he's no more with us. He once told me half of the people do not diagnose warm nodule. And once he told me this, I started looking for it. We used to write normal, because the warm nodule is warm, it is merging with the surrounding. So we are possibly writing a normal thyroid scan because it is taking the same isotope like the surrounding thyroid. So we used to write a normal thyroid scan. He only pointed it out to me, and then I learned it. So please spot the difference in these two scans. Anybody would volunteer, I would be very happy. Both are nodules, right thyroid nodules. Anybody? Correct, sir. So this one is hyperthyroidism because there is no salivary gland uptake. It's a grapes with
2017, PH Sauration in 2024, and more than 220 publications in national and international journals. Start your delivery, sir. Thank you. Thank you, Chairperson. Yes, sir. At the outset, I would like to thank the Sadhukhan 2025 team for this opportunity. I'm going to speak on hypophysitis, our experience of diagnosis and management. We, by working up at patients at SGS Medical College and KM Hospital, Mumbai, we have, based on the experience of managing hypophysitis, around 150 patients, of which primary were the most common, 82, and secondary, the next common, out of which secondary is the histiocytic disorders, tuberculosis, were the most common in our scenario. So, based on this experience, I would like to showcase various cases, what is the learning in diagnosis and management, and how do we differentiate. So, all these years, we have been diagnosing patients with of primary hypophysitis with histological criteria or clinical criteria, imaging, and hormonal involvement. And after ruling out secondary causes, we are supposed to diagnose primary hypophysitis. That has been taught. So earlier it was all predominantly done by surgical cases. So every pituitary hypophysitis, whether it be primary or secondary, would undergo surgery, and then histopath diagnosis was there. But over a period of time, the expert realized that patients with primary hypophysitis can be managed with pure clinical criteria, because the moment you go and disturb the pituitary, you will lose the chance of recovery of the pituitary axis. So what are these non-invasive diagnostic criteria we're supposed to look at? They have a typical clinical features and typical hormonal involvement, as these three patients were present to us. You can see this first lady who has come postpartum with galactorrhea and amenorrhea, which is a typical endocrine feature, and the other two one who come with right third nerve palsy with mass effect and headache and vomiting, and the other one with the right lateral rectus palsy. This is the neuroophthalmic features because of the mass effect which occurs due to the pituitary lesion. Typical hormonal features in primary hypophysitis, predominantly cortisol and thyroid is affected, and some amount of gonadotropin and GH affects less. But in our practice or in our experience, AVP deficiency is not seen that commonly in primary hypophysitis, and it is a feature of secondary hypophysitis which we need to look at. So in fact, even in our publication of around 40 patients of primary hypophysitis, the most common was thyroid, cortisol, gonadotropin, and some amount of growth hormone. AVP deficiency was seen in around 20% patients only. Typical imaging findings, what is seen? Looking at this patient, you can see a symmetrical homogeneous cellular supracellular mass with the homogeneous contrast enhancement. There is loss of postpituitary signal, there is stalk thickening, and the characteristic sign which has been seen is the T2 dark sign paracellular, which is a evidence of fibrosis around the pituitary which occurs after inflammation, which is very specific sign, but there could be atypical findings like necrosis, paracellular extension, dural tail because of the inflammation of the meninges, and a figure of 8 appearance. Definitely Gutenberg score will differentiate between adenoma and hypophysitis with a good amount of sensitivity and specificity, but there could be patients, where it's difficult to differentiate between these two, like this one. And that's where your hormonal evaluation and clinical features help us to differentiate between these two. This young lady coming with hypothyroidism and hypocortisolism postpartum in that setup, we will suspect primary hypophysitis. In NFPA, they don't get into pituitary deficiencies unless you get into apoplexia or a bleed in the tumor, then you get into all these complaints. And types of hypophysitis, that also denotes what kind of hormonal involvement can be there. In adenohypophysitis, you have cortisol and thyroid deficiencies. In infundibular neurohypophysitis, you have DI, GH, and gonadotropins. And if you have panhypophysitis, then you could have a combination of each and every part. So you see typical clinical imaging and hormonal features of primary hypophysitis. Let's look at the response to management, either conservative or steroid. What happens? So what we do at KM is we give a standardized, protocolized, high-dose methylprednisolone, 1 gram IV OD for 3 days, followed by 1 milligram per kg of prednisolone in reducing doses over 2 months, and you can see the improvement, what happens. The mass effect comes down immediately. You can see the lateral rectus palsy and the third nerve palsy improving. The size of the pituitary also comes down by 50-60%. And the most important part, where the cortisol axis which was involved has recovered post this therapy, suggesting that the pituitary function is rejuvenated with this anti-inflammatory therapy. So definitely you have to rule out secondary causes of primary hypophysitis, which we do by doing an FDG PET scan. We do CT chest to pelvis. We would also look at ACE and IgG4 levels and an ANA blot to look at autoimmune involvement. Associated autoimmune disease in primary hypophysitis is seen in around 15 to 20% of the individuals, as was seen in this case, who has come with isolated hypophysitis with the typical clinical features and the hormonal features. So what we did was an ANA blot where Jo antigen antibodies to that was positive, suggesting that there was associated dermatomyositis and polymyositis in this patient, so which has been shown in 15-20% of these cases with other autoimmune involvement. So you've seen characteristics of primary. Let's look at secondary. The most common which we have seen is histiocytic LCH and tuberculosis and IgG4. Let's look at how do they present. So this is a lady who has come with polyuria and polydipsia with AUP deficiency and hypernatremia. She had small, mild pituitary enlargement with a stalk thickening which is there, and we did an IgG4 which was higher than 1.4, which is a cutoff, 3.24, and she responded to steroid therapy, which satisfied the laboratory's criteria of a mass with IgG4 level which is high and response to steroids, which makes this diagnosis. So usually females will have a milder diseases in IgG4. They come with isolated hypophysitis. The IgG4 levels will be lesser, as against the males where you will have a severe kind of disease with multisystemic disease and higher IgG4 levels. So which can be picked up by FDG PET, which can pick up other systemic lesions like a pancreatic lesion which was seen in this case. Another case of secondary hypophysitis, you can see this lady who has come with amenorrhea, polyuria, polydipsia, and neck swelling with a goiter. And there is gonadotropin deficiency and GH deficiency with AUP deficiency. Cortisol and thyroid is not really involved. If you see the scan, it's got infundibular neurohypophysitis. And on FDG PET, there was uptake in the thyroid region. So you've got an extrapituitary lesion which is seen. So you have to look for these extrapituitary lesions because you can do biopsy of those lesions rather than doing biopsy of the pituitary. And that's how the patient has been diagnosed as LCH post-biopsy. So this was a very standard case where you've got extra pituitary manifestation, but sometimes you will not get extra pituitary manifestation. Patient can come with primary hypophysitis like presentation, and they don't respond to therapy, and they keep on coming back with recurrence or with worsening. Then you have to think that there could be other cause of hypophysitis, and that's where the patient developed skin lesions after 3 years of follow-up. She was a doctor with vulval and skin lesion coming after 3 years of hypophysitis. We could biopsy that, and then we found that it was LCH. And if you can't find anything, and if your suspicion is strong, you can go ahead and biopsy the pituitary, which we have to do for one patient, and you can get your diagnosis of LCH. Other sites which you can biopsy is xanthelasmas, cystic lesions in the lungs, in the bone lesions, and other soft tissue, whichever extraskeletal tissue tissues are available. So we've seen LCH. Let's look at another cause. This is a 24-year-old female who's come with headache for 2 months, diplopia, in diminution in the left eye with left lateral rectus palsy. So on evaluation, the cortisol was deficient, thyroxine was deficient, IGF-1 was on the lower side. On image, you can see that pituitary is slightly enlarged and there is homogeneous contrast, but on properly looking at the MRI, you can see that there is a hypoenhancing area at the corner of the pituitary, suggesting that this is not usual primary hypophyseal, this could be something else, and we usually do FDG PET for all cases of hypophysitis. So it showed uptake in the thyroid and in the paratracheal and subcarinal lymph nodes. So we could biopsy that and turn out to be tuberculous of granulomatous change where MTB was positive, and this was tuberculous hypophysitis, which we could diagnose and treat. So we put together data of tuberculous hypophysitis cases who've come with hypophysitis, not as a burnt out disease. So they've come with mass effect and they present like other primary hypophysitis. But when you look at the MRI of all these 9-10 cases which I have shown, it's very classical. If you look at it, it's not homogeneous enhancement. It's got a heterogeneous enhancement in the background of contrast enhancement around the pituitary, and there's irregular outline. So what we need to do is they come with mass effect. We have done biopsy of those pituitary, and you get granulomatous changes with caseous necrosis. But if you want to isolate MTB from there, you can't get MTB from there. None of our cases and others which have been reported in India, this is a case of bacillary tuberculosis from the pituitary. But they may have other associated tubercular lesions which you can biopsy, and there you may get your MTB. So experience. So how do you differentiate between tuberculosis, LCH, which is most common, and primary hypophysitis? If you look at the imaging, you can see that primary is homogeneous, regular outline, it looks very clean. This tuberculous hypophysitis is presence like primary hypophysitis, but if you look at the MRI, you can see an irregular boundary. There are hypoenhancing areas in the face of pituitary contrast. If you look at LCH, you can see that it doesn't come like an anterior. There is infundibular neurohypophysitis, and there are other systemic manifestations which are present. So this gives you an idea and a clue to differentiate between primary and secondary hypophysitis. There could be some other surprises, like this patient who has come with secondary amenorrhea, fatigue, and past history of abdominal tuberculosis but completed the AKT. There is panhypopituitarism there. On MRI, you can see the cellular and supracellular mass with some necrotic areas and also hypoenhancing areas there. On FDG PET, which we do for all patients, there was uptake in the multiple lymph nodes of hilar, mediastinum, right supraclavicular, and multiple pulmonary nodules. So we did a biopsy of those mediastinal lymph nodes of supraclavicular, which showed that there is granulomatous lymphadenitis, no necrosis or caseation, and MTB evaluation was negative, suggesting that this is not tuberculous cause. But because of mass effect, neurosurgeon decided to go for doing pituitary biopsy. It turned out, and the MTB reports were negative, suggesting that this is a case of double disease with sarcoidosis and tuberculosis there, because caseous necrosis is not seen in sarcoidosis. So we treated the patient with steroids as well as methotrexate and ADT, with which 3 months of therapy, you can see that the lymph nodes are completely vanished post-treatment. So we've seen these two types which are common. Drug-induced hypophysitis are becoming quite common because of the availability now and its usage. So this was a case of adenocarcinoma lung who's received durvalumab and was referred to us for evaluation, where patient had primary hypothyroidism and ACTH deficiency. It's known with these ICIs because it's a part of immune-related adverse events with type 2 hypersensitivity and type 4 hypersensitivity. So essentially there are two types of ICIs. One is CTLA4 inhibitors versus PD-1 and PD-L1 inhibitors. So CTLA4 blockers are one who come with hypophysitis. They come faster. They come after 2 months and they come with mass effects, and pituitary MRI can be on the show that there is pituitary enlargement there. But PD-1 and PD-L1 blockers are a milder as far as pituitary affection is concerned, and if they cause pituitary affection, they cause it after 4 to 6 months of treatment, and isolated access can be involved, MRI can be normal, and obviously if you have a history of ICI, then you don't have to do anything, no biopsy is required, and patients can be treated with appropriate therapy and replacement can be ensued. Now, this property of ICI causing hypophysitis can be used as a treatment modality for aggressive pituitary adenomas. As one of this case of pituitary Cushing's disease, who was very refractory to therapy, you have almost 20 years of follow-up, where he required bilateral adrenectomy, and then he went into Nelson syndrome. And post-Nelson syndrome also, he required multiple 2 surgeries, 2 proton therapies. We treated with temozolomide also, and there was no improvement with it. And so we discussed on discussion with the international experts, we started on pembrolizumab, with which, and it, as a side effect of hypophysitis, it also destroys the tumor there. And you can see the tumor size coming down, STH coming down from 2000s to below that. So 4 to 5 months we have a follow-up, and patient is doing quite well as far as STH axis and the hyperpigmentation and the local mass effect is seen. So we've talked about secondary hypophysitis. Let's look at primary hypophysitis, which we have experienced for last 20 years, and all 3 generations of prior HODs have contributed to the literature by treating in different way. So one of the first, Dr. Bhandarkar time, it was all histopathological diagnosis, where surgery used to be done. So when they used to do surgery, the mass effect, patients coming neurological symptoms would be taken care of, but there would be pituitary damage post-surgery, and you get into panhypopituitarism in surgery. Then Dr. Padma Menon, who took over, she was against surgery, so she wouldn't let her patients to be touched by surgeons, and she saw that conservative therapy also